Welcome to the Eisenhower Health Desert Cardiology Center lecture series. Today's topic will be heart failure detection and treatment, and today's featured speaker is Philip J. Patel, MD, President of Desert Cardiology at Eisenhower Medical Center, as well as Medical Director. Dr. Patel did his bachelor's in genetics at the University of California, Berkeley, with his master's and medical sciences degree from the Boston University Graduate School. After receiving his medical degree from Boston University School of Medicine, Dr. Patel relocated to the Midwest to complete his internal medicine residency and cardiology fellowship training program at the Mayo Clinic in Rochester, Minnesota. Following completion of 7.5 years of postgraduate training, Dr. Patel relocated to the Coachella Valley and was recruited by Eisenhower Health to join the Eisenhower Desert Cardiology Center. Please welcome Dr. Philip J. Patel, MD.
So it's either left heart failure or right heart failure. Then we further subcategorize that into the major breakdown of either systolic heart failure, diastolic heart failure, or you can have combined systolic and diastolic heart failure. And then further, we can categorize into either acute or chronic problems. Okay. So all heart failure, regardless of how we're classifying systolic, all of them stems from one or both of the following problems. Either there's a problem emptying the ventricle, which is an output problem, which is a failure of what we call systolic performance, which will lead to systolic heart failure. Or it's a problem filling the ventricle, which is an input problem, or a failure of diastolic performance, which leads to diastolic heart failure. Let me define one thing. Systole is when the heart squeezes. So the heart does two things. It squeezes and then it relaxes. So systole is when the heart squeezes. Diastole is when it relaxes and opens up. Okay. So it squeezes to eject the blood. It opens to receive new blood. Okay. Now, systolic performance is the ability of the ventricle to empty. It's the ability of the left ventricle to eject blood or to empty. And this is measured as the cardiac output. And we quantify this by a measurement which we call ejection fraction. This is the amount of blood that's ejected out of the left ventricle every time it squeezes, every heartbeat. The normal is anywhere between 60 to 65% is the normal ejection fraction. Any decrease in the systolic performance will lead to systolic dysfunction, and then systolic dysfunction leads to systolic heart failure. Now, diastolic performance is the ability of the heart to fill. So the heart has to open up, the left ventricle has to open up to allow blood to fill. This is cardiac input. During diastole, at the peak of diastole, the left ventricle, the left atrium, and the pulmonary veins are all in a common circuit, or called a common chamber, and is continuous all the way back to the pulmonary capillary bed. So if you have increases both in the left ventricle or the left atrial's pressure, that's the primary cause of shortness of breath. Let me show you a graphical example. This is the heart, this is the lungs, this is the left ventricle down here in red, this is the left atrium, and this is the mitral valve. So when the mitral valve is open, in this open position, this is the period of diastole where everything is in one chamber. So the left ventricle, left atrium, pulmonary vein, pulmonary capillary, they're all essentially one chamber, and they share the same pressure. So if you have an increased pressure in the left ventricle or an increased pressure in the left atrium, at this point in diastole when the mitral valve opens, that pressure will be transmitted through the pulmonary vein to the pulmonary capillaries, then into the lung, and the sensation of dyspnea or shortness of breath is what occurs. That's the pathophysiology of dyspnea or shortness of breath. But for the purposes of this lecture, I want to focus on systolic heart failure. We're not going to talk about diastolic heart failure, which could be a whole lecture on its own. This is systolic heart failure I want to focus on today. Now, systolic heart failure is exceedingly prevalent. More than 6 million people in the US have heart failure. more than 64 million people affected worldwide. So exceedingly, extremely prevalent. It is a serious lifelong condition, but with proper management, you can have normal life expectancy with proper management. So what are the causes of heart failure? Again, let's go back to what we talked about, systolic performance. It is anything, so systolic performance is the ability of the left ventricle to empty, or the cardiac output, measured by ejection fraction. So any decrease in the systolic performance, anything that causes a change in systolic performance will lead to systolic dysfunction. And then that will lead to systolic heart failure. So what are the big three? These are the most common causes of heart failure that we see. It would be coronary disease, or valvular heart disease, or arrhythmias. Think of the heart as a house. This house has 4 rooms, 2 on top, which are the atria, and 2 on bottom, which are the ventricles. The heart is separated by walls. In the bottom, it's the ventricular septum. In the top, it's the intraatrial septum. And the rooms have doors or valves in between the upper chambers and the bottom chambers. Then you have plumbing, which is the coronary arterial tree. Then you have wiring, which can create arrhythmias. Okay, so if we talk about coronary disease first, coronary artery disease will cause ischemic cardiomyopathy. If you have a heart attack, cells in the heart die. And when the cells die, they're no longer functional. They don't contribute to the heart pumping function. In fact, they become scar tissue. And that scar tissue just is kind of coming along for the ride. It does not participate in the heart pumping function. It doesn't add to the heart pumping function. If anything, then you have a decrease in the heart pumping function. So say you had a heart attack and you lost, say, 10% of your muscle, of the heart muscle, then your heart pumping function will go down by a certain amount. And the ejection fraction starts to go down. That is from coronary disease, which causes ischemic cardiomyopathy. Valvular heart disease causes valvular cardiomyopathy. This can come from certain valves which leak too much, such as the mitral valve or the aortic valve, or can be caused by stenotic valves, which cause restricted flow and increase pressure in back of that valve, such as aortic stenosis. So if the valve is severely narrowed, the aortic valve is severely narrowed, the left ventricle is pushing blood through this narrowed orifice, the pressure is so high that the heart tends to fail. On the converse side, for regurgitation, if you have, say, a leaky mitral valve or a severe mitral regurgitation, that causes increased volume going back into the chamber before, such as the left atrium, which then causes the heart to enlarge and get bigger and causes heart failure. This is valvular cardiomyopathy. When we talk about arrhythmias, we're talking about what's called a tachycardia-mediated cardiomyopathy. This can come from fast rhythms from either the upper chambers or the lower chambers. Some examples are rapid uncontrolled atrial fibrillation from the bottom chambers. Frequent PVCs can do this. Excessive stimulant drugs, which stimulate the heart, can do this. Think about, as an analogy, a car engine. If you take a car engine and you run that car engine 100 miles an hour, 24 hours a day, 7 days a week, that engine will conk out. Same concept with the heart. If the heart's going fast, 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 fast all the time, that heart will have heart failure. It'll conk out. It's a tachycardia-mediated cardiomyopathy. What excessive stimulant drugs we know, like, say, amphetamine-based diet drugs, very common to cause heart failure. And then other amphetamine-based drugs, which are given for people for narcolepsy or for trying to stay, such as Provigil, that has been shown to cause heart failure. And other illegal stimulant drugs, such as methamphetamine or cocaine, can cause a tachycardia uncontrolled, which can lead to a tachycardia-mediated cardiomyopathy. Then there are the other causes. First, the big three, then there's these other causes. And I've just listed these first three. Infiltrative cardiomyopathies, and there are many infiltrative cardiomyopathies. I've just listed a few here. Infiltrative meaning there is either a protein or a mineral that's being deposited into the heart muscle and affecting the systolic performance. common is hemochromatosis, which is infiltration of iron into the actual heart muscle, amongst other organs of your body, or amyloidosis, which is infiltration of a protein into the heart muscle or other organs, and causes a disruption of the systolic performance, leading to systolic heart failure. Infectious cardiomyopathies are very common. Of those, viral cardiomyopathies are the most common. HIV cardiomyopathy is common, and the new kid on the block is COVID cardiomyopathy, which we're seeing now more with the long haulers of COVID infection. Then we have idiopathic cardiomyopathies. Idiopathic means we're idiots and we don't know where it's coming from. So we have the dilated or non-ischemic dilated cardiomyopathies. These is a general category. We've tested for everything else. We can't find out where it's coming from, so we call it non-ischemic or dilated cardiomyopathy. Others, this should be in a different category. Excessive alcohol, it's in another category of toxic cardiomyopathies. I apologize for the slide error. And excessive alcohol is very well known to create a toxic cardiomyopathy from that. So regardless of the causes, one second. Apologize. Regardless of the causes of the heart failure, almost universally, heart failure has these signs and symptoms. Shortness of breath. Shortness of breath can start with minimal activity, and as your heart failure progresses, the shortness of breath can be so extreme. So even with minimal activities, you get short of breath, such as taking a shower, such as just getting up, going to the bathroom, can create shortness of breath. Swelling from fluid retention in the ankles, feet, legs, or increased abdominal girth. This is a very common symptom of heart failure. Extreme fatigue, weakness, rapid or irregular heartbeats, very common. Weight gain from fluid retention, very common. Waking up in the night short of breath is called paroxysmal nocturnal dyspnea, one of the most common symptoms of heart failure. And then orthopnea, or the inability to sleep flat because you feel smothered, you feel you just can't catch your breathing and you have to sit up. These are very, very common causes of symptoms of heart failure. The patients will tell you, I've been sleeping in the recliner all the last few days, or in the recliner all the time, because they cannot sleep flat. Here is a graphical example. It's from my old stomping grounds at the Mayo Clinic. Here's a picture of a normal heart. And if you see the outline tracing, that's the normal heart. But as you have heart failure, the heart enlarges, you get so much bigger. And this creates this fluid in the lungs. It creates the swelling in the feet and creates the sitting forward, holding, can't catch your breath. You have to lean forward to breathe. This is very, very common signs and symptoms of heart failure, almost universal. So how do we detect heart failure? Well, first and foremost, history and physical. See your doctor. And a good history and a good physical almost always will nail it right there. It's very, very common. We do subsequent follow-up testing to confirm our diagnosis from the history and physical. Blood tests are paramount. One of the blood tests that we use, I mean, there are other blood tests we do, but one of the blood tests utilized for heart failure management is BNP, which stands for brain natriuretic peptide, brain natriuretic peptide. Now, if this value is greater than 200, it's considered abnormal. Normally, people walk around with a BNP level 10, 15 tops. But as you get more fluid retention and stretching of the heart, when the heart stretches, it releases and leaks out this BNP, and we see it in the blood. I just had a patient in the hospital, and his BNP when he came in was 900. So it was classic heart failure. Then we also follow up with imaging tests. And of that, there are many: echocardiography, nuclear studies, cardiac catheterization, cardiac MRI, which is used now more exclusively for the viral cardiomyopathy, specifically COVID cardiomyopathy. We're utilizing cardiac MRI almost exclusively for that, and also for the infiltrative cardiomyopathies. And also, don't forget, standard plain old-fashioned chest X-ray is exceedingly one of our first-line imaging tests that we do in the management and detection of heart failure. But Echocardiography really is our go-to workhorse every day for heart failure detection and treatment and management. In fact, many patients will have serial studies done on them as we routinely follow their heart failure, make medication changes, or if they have changes in their symptoms, we would get another echocardiogram. It's non-invasive, it's safe, it's simply just an ultrasound probe put on the chest, and it creates moving images of the heart. So here's an example of a normal heart echocardiogram. And let me get it to play. Hopefully it plays, there we go. So let me orient you. This is the left ventricle. This is called the apical 4-chamber view. So this is the left ventricle here. It'll keep playing as a loop. It'll kind of reset. So here's the left ventricle. Here's the right ventricle. This is the right atrium. This is the left atrium. This would be one of the doors or the tricuspid valve you'll see here. Here's another door or the mitral valve you'll see here. This wall is the intraatrial septum. This wall is interventricular septum. Now, if you notice, if I put my cursor right here in the middle, see every single segment of the left ventricle is coming in very nicely. So every segment is getting thick. Every segment is contracting. This is a normal echocardiogram with an ejection fraction of 60 to 65%. Okay, nice, normal, healthy heart. Compare and contrast that to the next one, an echo of a patient with severe heart failure. Severe heart failure, look at this. Here's the left ventricle here, big, dilated. Look at the wall, thin and atretic. It's not contracting. This entire septum has suffered an infarct all the way around the apex, all the way to this wall. And the only segment contracting really is here at this lateral wall at the base. The ejection fraction is about 10 to 15%. So a very sick heart, very, very poor heart failure. You see the difference. We go back again so you can compare them and see the two together. Such a thin, a small ventricle, nice. Look at this contracting here and compared to the other one where it was so grossly abnormal. Okay. Now, so we have detected heart failure. We now have a diagnosis of heart failure. The next step is treatment of that heart failure. Paramount to all medical treatment, paramount to all device treatment is lifestyle modification. This is the cornerstone of all therapies for heart disease because no medicines or treatments will work if people do not change their lifestyle. Primarily low salt diet. For a heart failure patient, salt is your enemy. A low salt diet is paramount. The more salt you eat, the more fluid you would retain. Your heart's not able to pump that fluid, and you get more symptoms of congestion and heart failure. Regular exercise is key and important. Cessation of smoking is key and important. Weight loss is very, very important, as is daily weight monitoring. Daily weight monitoring is important because with proper diet and proper exercise and the medications and the heart failure and medications or device therapy, heart failure symptoms can be very well controlled and you can have a normal life expectancy. We follow body weight because the body weight should stay steady without any changes. Any fluid retention will cause an increase in body weight. And that's one of the first earliest signs that this person's heart failure is getting worse. So that's a clue that we use. We ask the patients to weigh themselves every day. And if their body weight increases by a certain amount, they're supposed to let us know. And that's a tell that something is going on. They're not absorbing their medicines properly. So as I said, daily weight is essential to monitor heart failure symptoms. So if the body weight goes up by 2 pounds on any given day, it's significant. And what it implies is, even in spite of the patient taking their medicines on a routine basis, they may have had more salt, they may have gone out to a restaurant, had a relatively salty meal or something like that. It creates fluid retention, primarily not just in the feet that you see, but also in the intestines. It is called bowel edema. And when you get inflammation, thickening or bowel edema, you can't absorb your medicines that you normally take. So as a result, you start to retain. And often this will lead to a worsening of fluid retention and the heart failure symptoms. When we detect it, we like to do early intervention with the administration of IV diuretics, because the pills, taking more pills won't work. You have bowel edema, taking more pills won't work. You need to have parenteral therapy or IV therapy. In the outpatient setting, if you do that, it helps the patient from going into the hospital or the emergency room. This is such an important concept that Medicare now has really pushed us to do what's called remote monitoring of body weight, because by doing this, we can keep the patients from going into the hospital. So we have across the country, they have these home body weight monitoring programs. We have that also at Desert Cardiology, where the heart failure patient is given a scale, an actual scale to take home and weigh themselves on that scale every day in the morning. That scale then transmits that body weight via a cell phone, which is just a smartphone, either an Apple or Android smartphone. They don't yet have a scale that's independent of the phone yet, but hopefully they're getting to that. And it transmits that to our nurses daily. And then any increase in body weight greater than 2 pounds is relayed to the provider. And then we can offer drug changes or IV therapy in our heart failure clinic that will help the patient from going into the hospital. Here is an example of the scale that we utilize. It's called the cardio base. And see how this scale connects to the person's smartphone, and that they stand on that scale every day, and it transmits that information to us every day for daily weight monitoring. So other than lifestyle modification that we talked about, daily weight monitoring, the primary treatment for heart failure is look at the underlying cause. Treat the underlying cause. And it's imperative to treat that root cause of heart failure. We go back to the big three we talked about: coronary disease, valvular heart disease, or arrhythmia, and then talk about all of the other ones as well. You want to treat the underlying cause. So for coronary disease, you want to revascularize that heart if necessary. Revascularize either with intervention and stent, revascularize with bypass surgery if necessary. For valvular heart disease, you want to correct that valve disorder, if it's either with replacing that valve or repairing that valve. If it's arrhythmia, you want to control those arrhythmias with either medication or ablations. And for all the other sources of causes of heart failure, you want to address those causes. Now, once the cause has been addressed, then we're talking about maintenance of heart failure, and this is primarily medication therapy. Of the medication therapy are the first, so for guidelines-based therapy, to clear that. For guidelines-based therapy, we have beta blocker therapy, ACE inhibitor, which stands for angiotensin converting enzyme inhibitor therapy, or ARB, which stands for angiotensin receptor blocker therapy, and then diuretic therapy. These are the three, the mainstay of therapy for heart failure. When we talk about beta blockers slow down the rapid heart rate. So when you're in heart failure, your heart is going fast on its own. It's doing that because the heart can't pump enough blood to your body. So the body's response to that weak muscle is make it go faster. So patients present with a tachycardia in heart failure. Mainstay first-line therapy is slow that heart rate down, allow that heart to fill better and pump better, okay? It also lowers the blood pressure. Not all beta blockers are the same. For heart failure, the three major beta blockers that we use have been confirmed in major, large randomized controlled trials. Of that is carvedilol, which is our main go-to beta blocker, then metoprolol succinate, or bisoprolol. Other beta blockers such as atenolol, bistolic, metoprolol tartrate, those do not have any indication to be used in heart failure. When we start beta blocker therapy, we always start at the lowest dose. We start all the drugs at the lowest dose and titrate them up as much as tolerated. There are side effects of beta blockers, hypotension being one of them. Common is fatigue, sometimes depression, sometimes erectile dysfunction in men. We have seen that. Now, ACE inhibitor or ARB therapy are also our second-line drugs that we use, the most important in heart failure. These drugs relax the blood vessels, which reduce strain on the heart and improve blood flow. They also lower blood pressure. The three major ACE inhibitors that have been shown by, again, randomized controlled trials to be effective in heart failure is captopril, lisinopril, or ramipril. And of the ARB drugs, the only one that has been shown in a randomized controlled trial, specifically the VAL-HF trial, was valsartan. Doesn't mean that other ACE inhibitors or other ARBs don't work. It is somewhat of a class effect, but these are the drugs that have gone through the rigorous trials testing. Again, we start at the lowest dose, we titrate up as much as possible. What are the potential side effects of ACE or ARBs? Cough is very common. Angioedema, or swelling of the mouth and the tongue, is common. And we also have to be very careful about using these drugs in renal failure patients. Not on an ACE inhibitor. So the next is diuretic therapy. Diuretic therapy is getting rid of fluid. It keeps fluid from building up in your body or lungs. You get rid of that fluid by urinating more frequently. Diuretic therapy is the third cornerstone of this triangle of beta blockers, ACE inhibitors, and diuretics. The third cornerstone is diuretic therapy. There are different diuretics that we use. We have what's called thiazide diuretics, which work in the proximal tubule of the kidney, of the nephron. And then we have loop diuretics, which work in the loop of the nephron. Thiazide diuretics are hydrochlorothiazide. The loop diuretics are furosemide or Lasix, bumetanide or Bumex, and then torsemide or Demodex. Side effects of diuretics are common. We see as you're taking a diuretic and you're urinating, you're also losing your potassium. Hydrochlorothiazide specifically, or all thiazide diuretics, can also make you lose your sodium. So you can get hyponatremia, you can get hypokalemia, your blood pressure can go down, you get hypotension. And again, we're always cautious using these drugs in renal failure patients. Now, aldosterone antagonists help the body get rid of sodium and water. This is also a very major drug that we use in heart failure management. Of these aldosterone agonists, they're diuretics, but they're what's called potassium sparing. So they don't create that drop in the sodium that we see with Lasix or the other diuretics. There are two major ones that we use, spironolactone or eplerenone. Side effects are common, such as, again, hypotension. In spironolactone only, we can see gynecomastia in men, which is male breast development. We do not see that in eplerenone. Then what are the novel therapies? These are the, quote, new kids on the block for treatment of heart failure. Of that, we now have what we call the ARNI drugs, ARNI, which is an angiotensin receptor blocker, traditional ARB drug, combined with a neprilysin inhibitor. And that's called sacubitril. Sacubitril is the neprilysin inhibitor, which has been put together in the tablet with valsartan, and they call that drug Entresto. Entresto, we use it now almost all the time. In place of a regular ARB, we would use Entresto. And I can tell you from experience, patients who have come in to see me who have had heart failure, I start them on the combination of carvedilol and Entresto, and diuretic if they show evidence of volume overload. And I can't tell you how many patients' ejection fractions have improved and have come up from this new combination. Entresto has been really game-changing in our treatment for heart failure. And then the newest kid on the block are from the diabetes world, sodium glucose cotransporter 2 inhibitors. And this is from the diabetes world. This is a diabetes drug called Jardiance. This drug has been given to diabetics primarily, but the associated notice was that diabetic patients who had heart failure who were on Jardiance did actually so much better. So in fact, the cardioprotective benefits of Jardiance is so profound that it has now been included as therapy for heart failure. So that's medical therapy. Then we can talk about device therapy. Why is this important? Well, we know that patients who have a low heart pumping function, we measure that by the ejection fraction. Patients who have an ejection fraction of less than 35%, in spite of having maximal medical therapy for an extended period of time, that patient is now at an increased risk of sudden cardiac death from the development of a toxic arrhythmia. Why is that? Well, remember I talked about the ischemic cardiomyopathy patients, and they get a heart attack and they lose that area of the heart. That area becomes a scar, okay? So now just envision that you have to, all of the cells of the heart have to be triggered by the wiring of the heart. There's wiring all through the whole heart. So if the heart beats once and that heart signal is going to the rest of the heart, if this area is a scar, it can't go, it has to go around that scar. The signal, the electrical signal has to go around that scar, because that's dead tissue basically, has to go around that scar to the live tissue and have that live tissue contract. So there's a delay, it takes time. But what also happens is as it's going around that scar, it's spinning back around on itself and it's creating this recurrent loop. And those recurrent loops in the bottom chamber can degenerate to what's called ventricular tachycardia, and then degenerate to ventricular fibrillation, which is a lethal arrhythmia. And unless you give somebody a shock, that would be a fatal event. So the implantable, because we can't walk around with a defibrillator and shock people, so we have an implantable defibrillator, is the device of choice in these patients, okay? Taking that one step further, patients who have a need for the defibrillator, they have continued heart failure symptoms in spite of maximal therapy, with an ejection fraction less than 35% and a widened EKG pattern, meaning they are desynchronous, they benefit from cardiac resynchronization therapy. This is where we put a third wire into the left side of the heart to resynchronize the chambers. So as I was saying, the electrical signal comes and hits the scar, has to go around and go to the other part of the heart. There's a delay. So if that's going down on the left side, the right side doesn't have any problem. The right side of the heart will fire first, then the left side will fire. So the right will go, then the left will go. So you're out of synchrony. The left, the entire bottom part of the heart is desynchronous. The left side is going before the right side, or the right side before whichever way it's going, but they're out of sync. So what we do, we put one wire in the right ventricle, one wire in the left ventricle, and adjust the settings on the pacemaker so that instead of going like this, they both go together. We have resynchronized the heart. That's cardiac resynchronization therapy. And it really helps with symptoms of heart failure. So to summarize, we know that heart failure continues to have a high prevalence in the, I apologize for the typographical error. Heart failure continues to have a high prevalence both in the world and in the United States, 65 million worldwide, at least 6 million in the US alone. And early detection is key to prevent adverse outcomes. Medical management and lifestyle modification are the cornerstones of therapy. Device therapy is also highly additive and helps reduce both morbidity, mortality, and symptoms. So with that, I'd like to say thank you very much for inviting me, and I will be open to take any questions at this time.